So this is a series of lectures on radiology, essential radiology for surgeons. So I'll be doing the first lecture, that is, the topic is the plain radiography. Okay, right. So I think that is, I mean, you all know and you are aware, and that is why I think you all are here, and that is why Dr. Galketi has arranged this lecture, because radiology has become an indispensable partner in modern surgical practice. I don't know whether it is modern, even in the yesteryears it was the case. Anyway, surgeons, I mean, we report or we give the reports, radiology reports, but you all are supposed to absorb it. So for you all to absorb it, I mean, to do certain things, you need to know how to, I mean, to some extent, to interpret imaging findings, but also to integrate them into, so you utilize it in preoperative planning, intraoperative navigation, as well as postoperative care. So at all stages of your day-to-day practice. So strong grasp of essential radiology, this ensures safer surgeries and more confident decision making, and after all, better outcomes for the, I mean, the person who is receiving, that is the patient. So for surgeons, I mean, if you master the essential radiology, that means that you all are trying to bridge the gap between the diagnosis and the surgical intervention. Surgeons must be familiar with the strengths and limitations. That is why there are so many modalities. There's no, I mean, we will be the luckiest lot if there's one modality which we show everything under the sun. But so you should know the strengths and limitations of each modality. So I have given in this table, you know, the imaging is good old biplane imaging, where you get X-rays. That is what I'm going to talk to you all. So mainly for chest evaluation and abdomen evaluation and trauma assessment and fracture localization. But be aware that the limited soft tissue detail. And of course, you have 3 cross-sectional ultrasound, especially used in fast exam in trauma and vascular mapping, intraoperative guidance, and CT and MRI. Ultrasound is it is cheapest and available, but it is hugely operator dependent and of course limited penetration. And CT, the drawback is the radiation exposure and the contrast, risk of contrast, especially in people with low EGFR, less than 30. And MRI, mainly the applications are neuro and musculoskeletal and pelvic surgery planning. The drawback is the long excision time and contraindications such as metal implants and claustrophobia. And of course, we can't forget the real-time biplane fluoroscopy. It gives intraoperative guidance in orthopedics, urology, and vascular, and there are many more applications. And of course, long duration of radiation, so you have the radiation exposure. So plain radiography, what is the current utilization? It is considered as cornerstone in medical diagnostics because it's a non-invasive, very, cost-effective method to visualize internal structures. Its applications, we all know, it spans over a wide range of conditions like chest X-ray. Still, it is used globally as a first-line imaging tool for chest assessment. No one will do a CT scan as the first line, especially in the ICU settings, which you need a lot of imaging and surgical patients. Most of them need ICU support. And when you think about the abdominal X-ray, especially in acute abdominal pain, and mostly it is happening now in the emergency department, the trend is actually declining with the introduction of ultrasound. Now it has, so I have figures only up to 2007. You can see there's a drastic decline, almost 50%. Then KUB, again, the calculus disease, we still do KUB X-rays. Even in Hewavithana hospital, we do about 5-6 KUBs in a day. But utility is declining due to CT KUB, which gives much more detail compared to KUB. And when it comes to the axial skeleton X-rays, trauma, still we do the initial imaging. We depend on the X-rays, but mostly we do axial skeleton for back pain and even sometimes tumors. Patient comes with back pain. And of course, appendicular skeleton X-rays, trauma, bone tumors still remain the mainstay of imaging when it comes to the appendicular skeleton. So you all should be aware of this fact. I'm not going to put this slide to say that don't do any X-rays or anything, don't do CTs, but to be aware of this fact. Chest X-ray is the least, radiation hazard imaging tools, 0.02 millisieverts. When compared to abdominal X-ray, which is 35 times, and abdominal CT, it is 500 times. So be aware of this fact when you're requesting X-ray. That is why we are inundated with ultrasound nowadays. Anyway, sometimes you have to do it. So when you think of the acute abdomen, the studies have shown abdominal X-ray rarely changes the management plan. I don't know how much you agree upon. It is often used as a defensive screening investigation because otherwise you can buy some time until you get the CT scan. Once you put the request, you can't wait. So it is a defensive screening investigation, especially in places where there's a lot of litigation going on. So when you think of the abdominal X-rays for acute abdomen, you know this 3-film abdominal X-ray series. You don't do all 3 at the same time, but I suppose you can identify this X-ray as the supine film abdominal X-ray, it's A. And you see the normal bowel gas pattern distribution, and normally the rule of thumb is 369. So small bowel is less than 3 or maybe even 2.5. There's one loop of small bowel here. And large bowel is usually more than 5 centimeters, but definitely if it is more than 6 centimeters, that is abnormal. So the normal peripheral distribution and presence of rectosigmoid gas. Then you have the erect X-ray. If you find it difficult to interpret, especially after hours, if you can't find the radiological leak, you may do erect X-ray. Because all these patients who come for these X-rays, they are not, they are in pain sometimes. Supine X-ray would be the best. But at times, if it is not revealing, you may have to do erect X-ray, or even if you are strongly suspecting of perforation and both X-rays are not showing, you may have to even do lateral decubitous, that is a left lateral decubitous, where you have to keep the patient for about 10 minutes for the gas to sort of gravitate up. So that is about the 3-film abdominal X-ray series. Then what you all should know, this especially the radiology surgical trainee, I can see a lot of consultants, not the trainees. What is the first line imaging investigation? What is the imaging method of choice for any disease or diagnosis? You should know these questions and answers. And what are the at-risk signs leading to urgent surgical intervention? We are talking about acute abdomen. So what is the first line imaging investigation? Plain X-ray series, but as I said before, not all 3 at once. So what is the imaging method of choice? CT abdomen. So if the plain X-rays are not revealing, you have to go for CT abdomen, or even if they are giving a certain diagnosis, you may need some more information. So you have to go for imaging method of choice. So what are the at-risk signs? You need to identify the at-risk sign, such as impending perforation, signs of bowel ischemia. What are the signs of bowel ischemia? Pneumatosis intestinalis, portal venous gas, and Pneumoperitoneum. So I'll be dealing with these things separately. So again, what is the role of plain radiography? Limited place for abdominal reading the workup of adult patients with acute abdominal pain in current global practice. Though we are sort of doing, we of course in hospital Peradine, we do about 10 to 15 X-rays, abdominal X-rays a day. At the same time, we do about 5 to 6 CT abdomen. So you can see sort of, the application of it, but the current global trend is now strongly declining. So can we apply this to Sri Lanka? I'm posing this question. If so, when and where? I mean, if we all the hospitals have CT scans, I think we can do it, but I don't think even in the global scenario, it is not the case. So in low resource settings, CT is not available. Patients present with acute abdominal pain should undergo supine X-ray with or without chest X-ray. Wherever CT is readily available, use of abdominal X-ray would probably be limited form. Maybe it is redundant. You do abdominal X-ray, you do a CT. I mean, if you think that this patient needs a CT, might as well drop the abdominal X-ray and straight away go for CT if the facility is available. But things like this radiopaque foreign body search and confirmation of fecal infection in elderly bedridden. So in the geriatric population we are heading, I think we will be doing more and more of these X-rays. So these two are clear indications. Even in the setting where the CT is readily available, you will be doing abdominal X-rays. So a word about that abdominal X-ray versus CT. I think you all know by now. Abdominal X-ray sensitivity is so low and negative predictive value is only 40 to 50%, whereas CT is almost 100%, preferred with IV contrast or plus or minus oral contrast. In case of small bowel obstruction, even now the trend is to give oral contrast because times it is useful for us to sort of, I mean, especially in elderly people, sometimes if it is additions or some partial obstructions, you may dilute with oral contrast, maybe a little therapy has a little therapeutic effect as well, but most of the time we do without oral contrast actually in young patients. And it will give an idea about site and transition point, cause of obstruction, where the specificity is very high, and of course, most importantly, signs of bowel ischemia, and also it may reveal other pathology other than what we thought. So this, this one you can see, this is abdominal X-ray. Intestinal obstruction is very well seen. The small bowel loops are dilated. You see the valvular conniventis, central loops, multiple loops, all these things are there. So, this patient was from our hospital when I was working. So then we did the CT scan because we could not find in a hurry. So what happened was there was this strangulated inguinal hernia. But later on, when we looked at it, it was there actually even on the X-ray. So the vigilance is very important. But as you see, you may think that you don't see the cause, but this is a rare instance. Don't think that you can see all these things in the X-ray. So very often we quickly do the CT scan. So this is a non-contrast CT that shows the obstruction and the cause of obstruction. We will move on to the real topic, small bowel obstruction. So these are the 5 questions to address in suspected small bowel obstruction, whether it is a surgeon or the radiologist or the clinician. Is there a small bowel obstruction? You have to establish the diagnosis. And where is the location of the obstruction, site of obstruction, and what is the cause of obstruction? And are there any complications such as ischemia, volvulus, or internal hernia? And of course, that is up to you all. How should the patient be treated? So these are the common questions. But so when it comes to imaging, we have to address these questions. Complete or high-grade obstruction. So, if it is complete or high-grade, you will not see fluid or gas beyond the site of obstruction. It is simple. And sometimes you may get incomplete or partial obstruction. This is a little dilemma. some fluid or gas passes beyond. I mean, when it comes to the X-ray, it is the gas passes beyond the obstruction. Then we are a little puzzled. Then strangulate obstruction, which may lead to intestine. So, is there any evidence on the X-ray? Intestinal ischemia, necrosis, or perforation. And then we may see closed loop obstruction, such as volvulus, and which may lead to subsequent ischemia. So these are the questions should come to your mind when you are even looking at the image. So when you think of the signs of classic plain radiographic signs of small bowel obstruction, you can see multiple dilated loops and this classic sign, the stack of coins, you can see in here the stack of coins sign. So this is about 5 centimeter dilated loop, almost the size of a large bowel, and central loops, even in this supine film. So you see the, and also this is called the coil spring appearance. So very often we see these things in small bowel obstruction. So if you're not too sure, I mean, if you have a doubt, you may do a erect X-ray, and of course that shows string of pearls or string of beads, whatever you want to say, because this is air trapped between fluid. So in the small bowel, we get a lot of fluid in the small bowel when air is trapped. And this is considered almost pathognomonic sign of small bowel obstruction. So if you have a doubt and if you see this, you are 100% sure that you have you are dealing with small bowel obstruction, and it is almost complete obstruction, very little distal bowel gas. So I have posed you 3 X-rays. The query small bowel obstruction, I think there's no doubt. So all 3 shows a supine X-ray showing multiple dilated small bowel loops. Of course, you see some large bowel gas is also still there. So whether it is partial obstruction or whether it is little early obstruction. And this one is the erect X-ray. You will see multiple air fluid levels centrally located, and you see only very little large bowel layer. Of course, you see gas in the stomach. Then again in the supine film, what do you think? This is complete or partial obstruction? So you hardly see any rectal gas. So absence of rectal gas, and you hardly see any large bowel gas. So it is almost complete obstruction with central small bowel dilatation. Then we will move on to the large bowel obstruction. So what are the classic radiological signs? Again, distal, this one is a descending colonic obstruction. So what we see is dilated ahaustral bowel loops. So these are all the way down. You can see the dilated bowel loop, and you can see this cutoff. So what is the drawback in plain radiography when you are dealing with bowel obstruction, whether it is small bowel or large bowel? I already showed you a case. So what is the drawback? So we don't see I mean, if you did a CT scan, you will see this. You can see this patient. You can see a sigmoid colonic cancer or descending colon cancer. So you can see this is almost this patient. So this is a dilated descending colon, and you can see at the same time the cause of obstruction, sigmoid colonic cancer. So I'm showing you another patient just to elaborate or just to highlight the importance of absent rectal gas. So whenever you see, I mean, you have a patient with distension bowel, abdominal distension and vomiting, and you do the X-ray and you see the bowel dilated large bowel loops or maybe small bowel loops, whatever, look for rectal gas. So absence of rectal gas. Rectal gas, I mean, it is present in almost, 100% in patients, rectal gas should be there. Rectal and cecal gas, you should be able to see. So if you don't see it, is a worry. So like in this case, so what do you think the site of obstruction? Mhm. More or less same to the, you can see a little bit of sigmoid colon even here. So it is a cutoff at rectosigmoid. So it should be at the rectosigmoid level. So these are some other examples of actually whether it is obstruction or not. There is a cutoff, gas cutoff, large bowel distal. So this is at the level of the splenic flexure, and this is at the level of the descending colon, and this is again at the splenic flexure. So what are the possible causes? So this patient have undergone CT scan, and this is what the CT scan has shown. It is an interception here. What about this patient? So this one has a thickened bowel wall and smooth narrowing, so it is not a cancer. It is a case of Crohn's ileitis. And this one, this is a very famous thing. We call it colon cutoff sign. So this is the colon, this is the stomach. So you can imagine the patient is very ill, and CT scan done immediately, it shows necrotizing pancreatitis. So this is the classic sign. It is called colon cutoff. So you don't get gas going beyond. You can see there's no gas in the descending colon. So remember this sign, the colon cutoff sign. So this patient, this is absolute constipation. What is your diagnosis? I think you all should know these things. Most of these things I have shown in undergraduate lectures, those who are comparer. Yes. How many of you all? 75 are there. I'm sure you all know the diagnosis. This is, what do we see? It is a loop of bowel towards the left side of the abdomen, and it is like an inverted U or inverted Y, what inverted U. And this is supine X-ray and erect X-ray. Also had been done. You see the fluid level. Again, you see the inverted U loop. So now does it ring a bell? Most important thing is to look for the rest of the large bowel air. In this patient, you see the rest of the large bowel, particularly the ascending colonic air. So, do you know the diagnosis now? So, I have given all the clues. Maybe too simple for you all, so you don't want to come out. So, it is sigmoid volvulus. It's a classic case. My friend Dr. Appa from Kalubovila gave me this case. Very nice film. Then the coffee bean. A bit of asymmetrical. I put some coffee beans for you to see this because this is not a typical coffee bean, but it is asymmetric. But this is the sign we use, the coffee bean sign. So what do you think? What is this here? White arrow is showing again little bit of descending colonic air. Of course, you see the fecal loaded ascending colon. So what is this? It is again the sigmoid volvulus, I think. You think the job is mine, isn't it? So in contrast, we have the cecal volvulus. So in real practice, this is a bit of a dilemma. So, but if you are really, if you really know your science, you will be able to figure it out. Again, you see a dilated loop of unduly dilated gas-filled loop of bowel. But in addition, you see some. What are these loops? Are these large bowel or small bowel? I think I'm talking to my computer. All are muted. So this is a small bowel loop. In this case, is centrally located, not as large as the large bowel. So what are we? So this is the clue which takes you towards this diagnosis, cecal bowels. But otherwise, when you have a loop of large bowel, towards the left hypochondrium. You wonder whether it is, because more common thing is the sigmoid volvulus. But look carefully, you don't see any colonic gas. So when the obstruction is as a cecal, you can't get bowel gas in the large bowel. So absence of large bowel gas, presence of small bowel obstruction takes you to the diagnosis of cecal volvulus. So it's the same thing that I have written here. Now sometimes we get pitfalls, dilemmas. We find it very difficult. We can't say whether it is small bowel or large bowel, or is it obstructed or non-obstructed. This is the commonest scenario. This is what you all bring the X-rays to the X-ray department and ask your colleagues. What about this one? So patient comes with abdominal distension and vomiting. Surgeon's dilemma, intestinal obstruction or not. What do you think it is? This one. No answer. Really disappointing. I thought surgeons are very sharp. So if you see a jungle like this, you don't know whether it is small bowel or large bowel. Unless proved otherwise, it is ileus. Both small bowel and large bowel are seen. Actually, you can't find out which is small bowel, which is large bowel. This is the jargon. Small bowel and large bowel look alike. Can you make out which is small bowel, which is large bowel? This is like a neonatal abdominal X-rays, because their bowel is not developed. So you see like small bowel, large bowel, everything look alike. So likewise, you see. So this is the ileus. So this is what you take you to the diagnosis of ileus. Small bowel and large bowel look alike. What about this one? Have you seen X-rays like this? Again, abdominal distension and vomiting. I'm not exaggerating this patient. Just ignore this one, there's artifact there. So the paucity of bowel gas. Now you see only a small. Now what do you think? This patient is having abdominal distension, vomiting, but no gas at all. What could be the scenario? Can anyone come out? Paucity of bowel gas. So we give differential fluid-filled bowel. So, small bowel loops, they are obstructed, but they are still having fluid. So when the whole of small bowel is having fluid, due to some reason, not much of gas, and those who have had excessive vomiting, it is supposed to be a gasless abdomen. So we call it gasless abdomen. So be aware of this situation. Also, when you see, don't be happy and go home when you see this kind of X-ray in a patient with abdominal distension and vomiting. At least try and do an erect X-ray abdomen and see whether you can see a string of beads or string of pearls, or get hold of somebody and do ultrasound scan, or you may have to do a CT scan as well. So this is another dilemma. Others, the problem we come across in patients with abdominal pain. Sentinel loop or adynamic ileus. So the word is self-explanatory. So what do we see on the X-ray? 1 to 2 persistently dilated small or large bowels, can be either of them. Often you may see air fluid levels. Why do we get it? Due to local irritation. Ileus in the same anatomical region as pathology. There may be pathology. It may be appendicitis, it may be pancreatitis, it may be whatever, cholecystitis. So local irritation gives you the ileus. The differentiating point is you look for gas in the rectosigmoid. Always gas in the rectosigmoid. So you know that there is no obstruction. May resemble early small bowel obstruction. This is the real problem. You may think that this may be early small bowel obstruction. Again, look for this thing. So this one, you can see RIF sentinel loop. So we tend to think of, if you all have the patient, you all examine the patient. So you put your hand, and if there's tenderness in the RIF, and if you see this, but remember, we don't do X-rays for appendicitis. but you may do X-rays because when the presentation is not very explanatory or non-specific, then only you go and do X-ray. So if you see this in that kind of situation, you may think of appendicitis. Nowadays, acute appendicitis is diagnosed, either clinically or on ultrasound, so you don't have to worry about it. But in certain centers, they do CTs. Then this one, I showed you the colon cutoff sign. Likewise, you can get even a small bowel loop which is dilated in this patient. So it is again a sentinel loop. So you may see sentinel loops anywhere. Most commonly, we see the sentinel loops around the appendix. As you can see here, I don't know whether it is visible. Sorry about the size of the picture. It is actually, I put it here because it shows appendicolith. There is a large bowel, the ascending colon is dilated. So in this case, it is the sentinel loop is the large bowel, and you see the appendicolith. So that is diagnostic of appendicitis. Even you don't have to bother about doing ultrasound scan. Then we will look at the complications of bowel obstruction. So these are also called at-risk signs. So if you see any of these signs, so you must know these signs. Pneumatosis intestinalis, ischemia, and perforation. So pneumatosis intestinalis. So look at this central film. It shows very, very extensive submucosal air. So this is wall air in the bowel loop. So this is pneumatosis intestinalis. You may not see a large, you should be, patient will not be lucky, but you should be lucky. These things are staring at you, but at times you have to stare at the pictures and look for it. You can see a tiny linear translucency in the bowel wall, and there's a small pocket of gas. You can see this may be even perforation or maybe pneumatosis. Triangular air shadow here. This is either pneumatosis or maybe even a small pocket which has leaked out. What about this one? This is portal venous gas. So you can see this arrow, you can see a branching pattern of translucency. So translucency in plain radiography is either fat or air. So air inside the viscera, of course, it is not as black as the bowel gas. Still, you see the air translucency in a branching pattern, and you can see some linear shadows, which are pneumatosis intestinalis, and some abnormal looking gas shadows. Sometimes not always you see in the wall, but maybe it is trapped, and you may see some abnormal looking gas shadow. So that is pneumatosis, which has gone into the portal vein. The thing is, this may mimic pneumobilia, so you should be able to, because this is not as dreadful as portal venous gas. So this is a case of pneumobilia. You can see gas in the biliary tree. You can see it is coming right down. Actually, gas in the biliary tree is more central. It is mostly around the porta hepatis, whereas a portal venous gas extends more peripheral. And you don't see like in the common bile duct gas. So you should be aware of these two, and you should be able to differentiate pneumobilia from portal venous gas. Earlier on, we thought portal venous gas is almost, really dangerous. You're almost dying, but now they say portal venous gas, since I think because of the imaging, we detect these things earlier, especially when we say this, we do a CT. We have had a couple of patients, portal venous gas, but they did not succumb. Then bowel perforation. So next to small bowel obstruction, this is the other thing. Any surgeon should be able to pick it up. So plain radiography, you can see 50 to 90% overall sensitivity, but if you take erect chest X-ray, that is the first line, if the patient can stand, but that may not be the scenario all the time. You may think of operation, but patient can't stand and pose for erect X-ray. If the patient can pose for erect chest X-ray, that is the first line and shows about 80 to 90% time, you can see the bowel perforation or intraperitoneal gas. Next thing, actually, if you are sure to get it, is with very high sensitivity, left lateral decubitus. Or next, even next may be the erect chest X-ray, abdominal X-ray, sorry. Supine abdominal X-ray has come down in the list, but this is the most of the time, this is the case because these patients are very ill. They can't be doing all these things. Once you all know better than me, they are clinical picture. So we do supine abdominal X-ray and we struggle to identify the pneumoperitoneum signs. So abdominal X-ray, very low negative predictive value. This is the problem. Negative predictive value is low. So CT is the gold standard. Even if you have 1 ml of air, you will be able to see it in the CT. But can we do CT in all the instances? If you're not in a center where there's no CT, no choice, you have to learn your pneumoperitoneum signs on the X-ray. So this is, two cases with little bit of soft diaphragmatic air. You can see a translucency. This one has whole lot of gas. Anyone can, diagnose this. But remember, even 1 ml of free air can be seen on even erect chest X-ray, not only on CT. Even tiny amount of air you can see on erect chest X-ray. And when you have a lot of air, this is a sign you tend to see this continuous diaphragm sign. This is from below the diaphragm, continuous diaphragm sign. Usually you see the diaphragm as two sort of hemidiaphragm separately, but when it is extensive, you will be able to see this continuous diaphragm sign. But interesting thing is continuous diaphragm sign you can see from the other side also. Look at this child, very ill. You can see the continuous diaphragm sign on the pulmonary aspect from the chest aspect, because pneumomediastinum also can produce. So you should be able to figure it out whether it is pneumomediastinum or are we dealing with pneumoperitoneum, right? Where if you see this continuous diaphragm sign. Lateral decubitus film. Same thing I showed you before. So once you keep the patient for about 5 to 10 minutes, gas tend to accumulate in the less dependent portion of the abdomen. So we are doing the left lateral because of this reason. We are looking at the gas, intraperitoneal gas against the liver. So that is what we are looking at, the contrast between the soft tissue and the air. So air translucent, as you can see, but this black arrow is showing the fluid level. Sometimes you see even when there's a lot of fluid in the abdomen, you may even see a fluid level. Don't worry about it. So what are the signs on supine X-ray? I think all of you are aware of the Wriggler's sign. So if you see this beautiful on either side bowel wall, that is the Wriggler's sign. But not all the, cases are like this. But be aware or not. When it is overlapping with the other bowel, you may find it difficult. But if you look carefully in almost all the loops, you need a lot of air to get into this scenario. So if you see this this is a normal abdominal X-ray, you will appreciate that only the inner side of the bowel wall is seen. You don't see the outer side. So you don't see a line like this. So you will see, because it is merged with the rest of the soft tissues in the abdomen. So you will not see a line, you will see only the inner margin of the gas shadow. Then what about the other signs? So there are about 15 to 20 signs of pneumoperitoneum, but these are the commonest signs I am showing you. And this is if you have a fair amount of substantial amount, you will start seeing the falciform ligament sign. So you can sometimes you see the soft tissue density of the falciform ligament, which we do not see here. And other thing is the subhepatic. Usually you get a large triangular collection underneath the liver, again because of the contrast, soft tissue contrast and the gas translucency, you will see this subhepatic. So these three are the easiest signs that you will come across. But I mean, if I were to do a lecture on pneumoperitoneum, I think there's material for that. There's so much of pneumomediastinum and pneumoperitoneum. They people have found so many signs. What about this one? Do you see any abnormality here? You all have come decided not to talk today. X-ray is little bit soft. But this is the usual, our life sort of, I mean, this is what we see, isn't it? Can you see? You see some stippled calcification in the region of the pancreatic head. Of course, you see some sentinel loops as well, but definitely not the colon cutoff. But so this is a patient with pancreatic calcifications. So this is much more advanced version, much coarser calcifications. So this goes all the way from the head of the pancreas to the body to the tail towards the splenic infection. So usually even this one you can see because of the bowel gas, you don't see it clearly. So you can't miss pancreatic calcification. Sometimes you may see only one or two. So don't, I mean, if you're lucky, you will see like this. But remember, if you see anything very close to the spine at the level of the L1, L2, you have to be aware of the pancreatic calcification, especially in the head of the pancreas. Okay, then I have dealt with the abdominal X-rays, few examples which I could figure out, but there are so many actually. The time doesn't permit to do all those things. X-ray KUB. So I want you to reiterate this because for the last 30 odd years, I tried to change this, but I could not. I failed in that. Bowel preparation not considered mandatory in X-ray KUB. So I'm requesting, please don't give laxative for 3 days in all patients. I found out the problem is nurses, they have been told about 30 years ago, whatever the time, I think maybe from the inception of our hospital in Peradeniya. So they are given 3 days, whether you have diarrhea or constipation, patient gets 3 days preparation. Do so for those who are constipated. Prepare the patient according to the bowel habits of the patient. If the patient has a daily motion, you can give Dalaclax suppository in the morning and previously Dalaclax 2 tablets. That is more than enough. And the large stones, anyway, we will see. You are not going to pick 1 millimeter, 2 millimeter stones on the X-ray. The resolution is not that good. So this is the latest, I found it is not considered mandatory, maybe with the evolution of CTKUB, because sometimes we see tiny calculi. Patient is in howling in pain. We don't see anything in the X-ray, and we all know very well only 70 to 80% of the calculi are seen in the X-ray, but all the calculi are seen in the CT. So because of that, don't go and ask for CT in KUB in all the patients. But I mean, be aware of this fact. Prepare them accordingly. Because a patient with a renal colic, in my opinion, can't. If I have a renal colic, I can't wait for 3 days for preparation. I don't know how we all manage. Anyway, so I have posed you 3 X-ray KUBs. Which one would you like? A, B, or C? Hmm? Obviously, A is loaded with fecal matter. This is not bad. This is, of course, very clear. So maybe one of your patients who had 3 days calculus or whatever the purgative. So which is acceptable? Definitely, this is not acceptable. So I'm sure that there had not been any preparation. So you have to ask before sending the patient for the X-ray KUB whether that patient has had a motion. I mean, if a patient opens bowel once in 3 days, this may not work on some people are really constipated. This may be, I mean, you can take it as acceptable. Don't do X-ray. I told you it is 35 times more than the chest X-ray. So I think this is also acceptable. But this is the best. But don't repeat this kind of X-ray thinking this bowel preparation is not good. So this is the proper preparation. And what about this? Is this a good quality X-ray KUB? I mean, from the radiography point of view, it should be a nice X-ray showing all the densities of plain radiography, like the gas in the bowel, fat in the properitoneum fat line, the soft tissue shadows like psoas, ribs, pelvic bones, everything you should be able to see in one go. But that is not the case. Actually, I'm putting this X-ray because, I mean, this is, myth of a medical students actually. So I thought of putting this also. Having bowel gas is not a problem in the X-ray KUB. So presence of bowel gas does not mean a poor quality KUB X-ray. Fecal matter is the enemy. So look for bowel. Bowel gas is actually friendly because through the gas we can see the calculi. So this is a good X-ray. Right. So I have given you the X-ray sensitivity and specificity. So here are you can see the calculi. In this X-ray, it is obvious. You can see the calculus. This is the place you look for at the tip of the transverse processes. That is the course of the ureter. And you know, up to this place, that is the upper ureter, up to the pelvic brim, and after that, the middle ureter and the lower ureter. So this is upper ureteric calculus. And this one, where is the calculus? Do you see a calculus here? No? Or don't want to talk? Can you see? This is the calculus. So it's a urethral calculus stuck there. So that is the can. So look for at the symphysis pubis. That is why the radiographers, they are supposed to include the X-ray KUB up to the symphysis pubis. So what are these? Can you identify this one and this one? What is this? All these pictures I took from my undergraduate lectures. Most of these things. So just to recap. So this is a nice staghorn calculus. In our country, we get even bilateral staghorn calculi like this. So this goes into all three calyces. If a calculus in the renal pelvis, which goes into one of the calyx, or maybe two, it is called a staghorn calculus. And this is a vesical calculus. Sometimes people find it difficult, especially in females, like in this one. When there is a radiopaque area, whether it is a fibroid calcification or whether it's a bladder calculus. Bladder calculi are always in the middle because they tend to gravitate in the supine position, and usually they are oval shaped. So this is an uniform or maybe little lamelated, but usually they are uniform. So it is a vesical calculus. The main point is the central location of the calculus. Then the mimics of calculi along this is the biggest problem we have. So I have shown you with arrows and this mark. So what is this? Is it a calculus? Yes or no? Hmm? No answer. Can you all hear me? I can see Achala's smiling face. Achala, can you hear me? I don't know whether
Yes,
I'm talking myself. I wonder whether I'm talking to
no,
myself.
no, the
Yeah.
others are muted, that is why.
Right. Never mind. So this a calculus or our problem when it is happening in the right hypochondria, whether it is a calculus in the kidney or whether it is in the gallbladder. So how do we differentiate? Look for lucencies within the stone, within the calculus. Even if it is small, tiny, you can see this. You can see a translucency within the calculus. And what about this one, the yellow arrow? I think for the last couple of, decades, I have been putting the medical students into this. These are phlebolytes. So they are below the scale spine, nice and rounded, even there, even the tiniest phlebolith, you can see the central translucency. So don't request CT for this phlebolyths. You can diagnose phlebolyths now, I suppose. And other thing is the costal cartilage calcification. Usually they are nice and symmetrical. Look for the other side, and they are multiple in a row, and you can figure it out when you figure it out. The way the course of the rib, you will see it. So these are the three mimics of calculi along the urinary tract. What about this one? What is this? So I am into this nowadays after retirement, mindfulness. Be mindful of different densities on plain radiography. I showed you before the gas density, fat density, and also. What density is this one? It is the same patient. You can see even the fecal matter, same. So this is a metallic density. Nice smooth margin. Nice smooth margin, metallic density. It was on the left side before and after. This was in the morning. This was in the afternoon. So now it is in the C cup. So it is moving. So we are happy. So it is a coin. The child swallowed a coin, and this was the on series of abdominal X-ray. And this is what I told you at the beginning. Abdominal X-ray is definitely for the swallowed coin. You don't do CET or anything to see where it is. You do because it is opaque enough to see it on the X-ray. So this is one of the indications for abdominal X-ray. I don't think this will ever die. This indication. What about this one? I have given you the diagnosis. This is metallic shrapnels. You can see tiny, tiny, tiny shrapnels. Even they are tiny. These are sub-millimeter, but still you can see it here. So you can see this bomb. This is a bomb blast victim. So you can see the metallic densities. So we saw the calcific density, metallic densities, gas, and everything we have seen. So this is this thing. I don't think any one of you all do this thing. Don't request X-rays for gallstones. This patient did not come for X-ray for a stone. This was a lumbar spine X-ray. You know what is the diagnosis? A 35-year-old male with backache was subjected for lumbar spine X-ray. You know what is the diagnosis, don't you? Acroiliac joints are totally fused. You get a kind of a bamboo spine. So what is this? What do we see here? I put this X-ray because this is the other way we used when we were medical officers and registrars. We used to do this kind of X-rays. Before ultrasound era, to find out whether it's a renal calculus or gallstone. So I told you before that lucency inside is taking you to the diagnosis. But the other reason is why I showed you this is, if you don't see this translucency, like in this one, do a lateral X-ray, and you can see if you don't have ultrasound due to some reason, venous stones are projected over the spine, whereas gallstones are anterior. That's a fact I wanted to show you. And this is a gallbladder calculus in a patient with ankylosing spondylitis. AS is ankylosing spondylitis. So surgeons do need chest X-rays, don't. But I have not put X-rays like pneumonia and things stuff like that, miliary TB or things like that. I thought I will discuss some X-rays which are more relevant to you all. Pneumothorax. So both are erect X-rays. I mean, patient is not that ill. Patient could stand for these X-rays. What are the signs? So what are the signs? You see this very sharp visceral pleural line and gas translucency. You can see the air translucency without any lung markings. Lung markings all stop here. See the visceral pleural line. But mediastinum is not shifted. Hilum is fairly okay. But in this patient, you see this is the relaxed or the collapsed lung. Entire lung has come down to the hilum like a deflated balloon. The entire hemithorax is translucent. Compared to this side, you see a lot of lung markings, normal lung markings. Here you don't see lung markings. Entire hemithorax is. So there is a discrepancy between the transparency. Highly translucent lung compared to a normal lung. So I'm posing your question, will you put an IC tube to patient A? I'm sure you will put IC tube to patient B because there's a mediastinal shift also, entire lung is collapsed. Will you put a tube to the patient A? Any kind person who would answer my question? No luck. So this is the rule of thumb. A is for Americans, B is not for Iran, B is for British, okay? So this side, at the apex, it should be more than 3 centimeters. So this is how we gauge. And B on the mid-lateral chest, it should be, the Britishers thought it should be more than 2 centimeters large. That is the rule of thumb, roughly you have now, of course, you have other parameters like saturation and stuff like that. But when you see the X-ray, this is the rule of thumb. Quickly, whether you decide whether it is a large pneumothorax or small pneumothorax, right? This patient, pneumothorax, so in some situations, maybe the patient is in the ICU, or polytrauma, patient has got pneumothorax. So in the supine X-ray, how do we know whether there is a supine pneumothorax in a supine? Deep sulcus, lateral sulcus. So claustropenic angle. Look at the claustropenic angle here, which is very much lower down. It may be not included even. It is very so deep and hyperexpanded hemithorax. Compared to this one, you can see the hemithorax is increased translucency. You can see the lung markings because this is a 2D picture. So you can see through the pneumothorax, you can see the lung markings. You may or may not see the visceral pleural line. And increased sharpness of heart border. Now you have to think 3D, though this is a 2D film. The air which is contacting the heart is giving a very sharp border to the heart compared to this side. And of course, there's a clue, there's subcutaneous emphysema, or there may be even rib fractures, right? So we need to learn how to diagnose pneumothorax in a supine film. So this is much better demonstration, deep sulcus sign, very much deeper because this was not there. So I put this X-ray. So the sulcus is very much deeper. But mind you, the convexity of the hemidiaphragm is still okay. Can you appreciate that? Convexity of the diaphragm is still, usually it is in the mid-clavicle line, it is okay. What about this one? What is your diagnosis? I'm sure you will put IC tube here. You see all the signs, hypertranslucent, hemithorax, no lung markings, relaxed, collapsed lung, at the hilum. What are the additional signs? You see the shift of mediastinum to the right. Usually, only 1/3 of the heart is on the right side. This is like half, isn't it? 2/3 is on the left side. So definitely there is mediastinal shift, though the trachea doesn't look so. Look at the diaphragm. Earlier when I showed you, there was sizable pneumothorax, but the diaphragm was convex. Here the diaphragm is flattened. So this is the case. You have to be very quick. You can't go for a cup of tea. You have to immediately put the IC tube. There may be hemodynamic disturbance, engorged neck queers. It is attention. Sorry. I have gone beyond 1 hour. Do you want me to continue or? I got the permission from Dr. Galketi, of course, when I set the lecture from the last lecture.
Yeah, madam, you can go, madam.
Thank you. So in the pneumomediastinum, you know the pathology, gas may originate from lungs, trachea, central mucosa, whatever, especially the esophagus. Gas may track from the mediastinum to the neck or abdomen. I told you so many signs on pneumoperitoneum, similar number you get in the pneumomediastinum. If you can concentrate actually some of these things, I think that should be okay. We leave the rest to the radiologists and the emergency physicians. They take a lot of trouble to learn these things. So this is the most easiest sign. You see a linear density, which is parallel to the heart. But be mindful about the pneumopericardium. Pneumopericardium will never go above the pulmonary trunk. It will stop here. So that is where the pericardium stops. So if you see the translucency going above the hilum, that means that is pneumomediastinum. And of course, there are, you can see some emphysema here in the mediastinum. So a lot of gas translucencies. So it is. So those are the main signs that you see in this patient for pneumomediastinum. And this is an interesting sign. Sorry. You can see the sort of two lines going, one along the aorta and another one along the diaphragm, so that we call it neck, this thing, Snecklerian V sign. So sometimes we see this, but you don't have to bother so much. But sometimes this may be the only sign. That is the thing. And this is along the diaphragm, you may see some. And this is one of the sort of rare signs we see very rarely. This is double bronchus sign, like that Wriggler sign you see. You start seeing on either side of the bronchus. So there are so many signs, but at least you remember the parallel line to the heart or mediastinum. And this one also is a sign. These are fairly rare signs. And this one I showed you before also. This is the continuous diaphragm sign. This is on the chest side. So that is a sign of pneumomediastinum. I showed you before the pneumoperitoneum sign. So on either side, you can get continuous diaphragm sign. Then from the chest and abdomen, we will move on to the axial skeleton. And when you think of the axial skeleton, spine and pelvic trauma, you can see this statement only a screening tool, mostly supplemented by CT. But even if you do it as a screening tool, look for these indicators of instability. If you get more than one vertebral column, you know the Dennis columns, that's the simplest method. Increase or reduce intervertebral disc space height, maybe even increase sometimes. Increase interspinous process or interpedicle distance. Or if you see facet joint widening or vertebral compression more than 25%. So these are the indicators of instability. So we'll see some examples. Can you identify any abnormality here? I mean, this is one of the things that I like to see on the cervical spine AP X-ray. Other than the tracheal compression from the goiter, this is another place where we look at the AP spine, cervical spine X-ray. And whether you can appreciate the cervical spinous processes, you can see them very clearly because in this area we see the trachea and the pharyngeal layer column. I don't know whether you could appreciate these two. You don't see the spinous process, particularly here. You see the spinous process below, but you don't see it here. So if you don't see the spinous process in a cervical spine AP X-ray, you mean you are looking at a serious trauma. So this is the lateral. So you see the reduced disc height, forward displacement of the vertebral body, and interspinous distance. Look at the interspinous distance. It is almost doubled. And look, remember the three lines that we draw in the cervical spine: anterior vertebral line, that is disrupted; posterior longitudinal ligament line, that is disrupted; spinal laminar line, that is disrupted. All the lines, and pillar line, that is along the facet joints, almost all the lines are disrupted. So this is the CT picture. You can see this is the facet joint, nicely fitting facet. This one facet is subluxed here. You can see the facet below, facet above, they are okay. So this is the unilateral facet dislocation. So if you did not pick this up, you won't order a CT, but nowadays all the head and neck trauma, you do a CT scan, head and neck together. Then the indicators of instability, I told you before, more than 25% compression of the vertebral body, increase interpedicular distance. Usually the interpedicular distance increases one by one at every level increment, 2 millimeter increment. But here you see, you don't appreciate much, but you see some increased density in this vertebral body. Otherwise, you think this is a normal looking vertebra, isn't it? But look at this one, this small X-ray, sorry about the size. And this shows definite interpedicular distance widening. Look at the pedicles. These are some, easily seen structures in the spine. So you see the interpedicular distance widening. And on the lateral, you see the all three columns, cone, Dennis columns, and it has retropulse into the spinal canal. So this is a very bad, unstable injury. When you look at the appendicular skeleton, so plain X-rays, I made this statement before, excellent screening tool for fractures. You don't do anything, even the Ayurvedic doctors ask for this X-ray, so they also know how to read these things. Plain X-rays, this is one of the non-replaceable indication for plain X-rays. Ideal for managing injury entirely in majority, that is good enough. But CT is indicated when the joints are involved or in special sites such as tibial plateau, calcaneum, talus, scapula, radial head, not always, neck of the femur, and acetabulum. So you should be aware of these things. Otherwise, we see sometimes the people who need dislocations are missed because it was not diagnosed on plain radiograph, and missed and CT was not requested. Patients later on come with scaphoid necrosis. So you should know when to ask for CT. So this is such example, tibial plateau fracture. So you can diagnose the fracture, but you need some more information, Schatzker type. So when you see this, you can see the fracture is not just a fracture, it is depressing the lateral articular surface. So you need this kind of information. So you need a CT to classify the fracture. So this is a obvious scaphoid fracture at the waist. What do you think of this X-ray? You can see this scaphoid bone is completely white now. Particularly this area. So it is scaphoid necrosis. Few quizzes. If you are not too tired, or if you want to leave, you are, more than welcome. So this one, why am I doing this? What are the signs you see? What is your diagnosis here? It is pneumomediastinum in children, actually. This is for pediatric surgeons. This is the sale sign. This thymus is elevated because of the pneumomediastinum, and you get this continuous diaphragm sign, and you see this deep sulcus sign. You get so many things. There's pneumothorax, mediastinum, pneumothorax, and subcutaneous emphysema. So it is a very bad trauma patient. Oops. Sorry about these lines. I don't know why it came. Another one. So this is the same case that we did like before. So I am doing the quizzes, not y'all. Huh? So this is tension hydropneumothorax. Earlier we saw the pneumothorax. So this is hydropneumothorax. What about this one? Is it sigmoid volvulus? So I can give you a clue. Is it sigmoid or cecal? Samita? I can see some names on the screen. Dinoshika. Is it sigmoid or cecal? No gas in the large bowel. So it can't be sigmoid volvulus. It is a cecal volvulus, though it is looking this side. But it is because absence of gas in the large bowel. It is cecal. Yes, it is cecal volvulus. Gas would not enter the large bowel. But there is no small bowel obstruction here, no gas in the small bowel. But definitely it is a cecal volvulus. What about this one? Have you seen this before? I'm sure you would have seen. This is not Pneumoperitoneum or gas on the diaphragm, but you can identify these large bowels, loop, going in between, interposing between the diaphragm and the liver. So this is a so-called Chilaiditi sign, Chilaiditi syndrome, or whatever they call it. So when you see it for the first time, you get a step back. So don't get that. Just be aware of the Chilaiditi signs. So this is the final quiz. What is the diagnosis? I have given you arrows all over. I'm sorry about these lines. I don't know how it came. So in the first X-ray number A, you see some aerobelia. In the X-ray B, you see some dilated bowel loops, and it stops in the right iliac fossa region. So when you see aerobelia, you know one possible thing is passage of a calculus, isn't it? So the patient has just passage of a calculus will not give you small bowel obstruction. So the diagnosis should come to your mind is this. This is a gallstone ileus. So you can see, I mean, it is not shown on the X-ray. You can see the reason, very thin line of calcium is there. Most of the stone has central lucency, fatty or cholesterol-like. So stop. So, and this is the aerobilia again shown on the CT. So this is a case of gallstone ileus. So I think that is the last one. Sorry about taking 15 to 18 minutes. Thank you very much.